Good afternoon. This is Gail. Wanted to thank you all for joining me this afternoon after a we had a 4-day weekend. I guess some of you also had a 4-day weekend, but I hope you all had a happy Thanksgiving. Some things have finally come together here for 1/1/18 changes. So I wanted to have a webinar to go through some of these. Actually, I also got an email. There'll be 2 other emails that I got today about some other changes that'll be coming January 1st, but they were too late to get on the agenda, and I probably don't have enough time to include them. We will talk about them at the all-plan meeting on Friday. I'll put them on the agenda, and we can discuss them. I don't think they're as big as at least 2 of the items we're going to talk about today. Those 2 items are going to consume most of our time. I think it's warranted that we postpone it anyhow. And I gotta get my head around the change and how to convey that to you all so that you can take home the key elements and work on implementation. So I want to start out today by talking about things that are going to change January 1. Okay, so some of these things are things that we've talked about before, but today gives us an opportunity to go into it a little bit more. Can they talk back to me on this?
We can unmute people individually.
Yeah, so we'll need to unmute people as we go through some of these things that I want to cover today. But the first item that we're going to talk about is the carve-out for emergency ground transportation benefit. We're going to talk about the new components for the children's mental health law, which include adding depression screening for adolescents ages 12 through 20 and the caregiver of a child who is between the age of 0 and 6 months. We're also going to spend a significant time talking about the collaborative care management policy. This is a new policy, and we want to be sure that we're all on the same page about what it looks like and how it will be implemented. In addition to that, we also will lastly talk about the potentially preventable readmission policy. Some of you may have been involved in the crafting of that policy, but it will mean significant changes for you 1/1/18, and I want to have time to talk about that. Make sure you understand. We can leave time on the Friday meeting to next Friday to talk about some of this more in depth, but you're also welcome to send me questions and talk or bring up your questions today as we go through it so that we can support your implementation. So let's go to the next screen. So emergency ground transportation carve-out. So Diane shared the procedure codes with you. I believe it was a couple months ago. I'm going to assume that you all received them and that they were distributed to those who need to know. We see it as implementation of tasks that include system changes and provider and potentially client education. So how are you all doing with your system changes? Were you able to use the codes that Diane sent you to carve out the benefit and assure that your plan didn't pay for a service that they are no longer responsible for 1/1/18, or are you in process of implementing the changes around that procedure code list?
Would you like to hear from the audience?
Mm-hmm.
At this time, we're going to unmute your phone lines. If you are interested in giving feedback, go ahead and use the audio option.
So can somebody from AmeriGroup please raise your hand and share with me how you're doing in regards to implementing this carve-out?
Gabrielle, we've unmuted you.
Okay.
This is actually Gabriel from CHPW. No problem. And just to let you know that our operations team, configuration team, we're on target. We have no concerns at all for this.
Thank you, Gabe. And does that include making sure your providers are aware of the change?
I'm confident in that. I will follow up with you. We have provider communications going out, and this has been a topic for talking points. But I'm going to say yes, and then I'll loop back if that's not the case. But I'm confident that we've been educating appropriately.
Thank you very, very much. Another plan, please raise your hand.
We have Iani Spencer. Iani,
Hi.
you have the floor.
Hi,
Hi, Lonnie.
Hi, we're configured and ready to launch, and provider communications have gone out to indicate the change.
Thank you much.
We have Kathleen Archer.
Oh, hi. I work with Lonnie, and yes, I agree. All the auth required rules, everything has been changed and ready to go.
Great.
We have Jennifer Carlisle.
Hi, coordinated care is, we've completed configuration and we're going to be ready to go 1-1, and we have already fact blasted our provider community.
Excellent.
We have Alan Fisher.
Hi, so United Healthcare, the configuration is done. We're working on the provider communication.
So,
And that appears to be all the hands that we have.
somebody on the phone from Molina?
Our phone participant, or participants from Molina may be only calling in, so they do not have the hand raise function.
Oh, okay. Okay, Melina, if you could just send me an email. Who did we hear back from? Do we know, Krista? Erica? Melina, if you can, just send me an email. Let me know how you're doing. Erica, I see your name here as someone who was going to attend. Molina members, my email address is gail.kreiger@hca.wa.gov. So if you could just send me an email and let me know how you're doing on that, I'd appreciate it. So let's move on to something, the second change. Changes to the Children's Mental Health Benefit. Now, y'all that attend the all-plan meeting recall that Colette went through this a while back. I'm just going to go through it again a little bit, but we actually have to get down to operationalizing it. So our focus today will be slightly different, not just informative. So the new law requires that we be more accountable. And when I say we, you guys, I don't have a mouse in my pocket. I'm talking about you all and us. And that we need to be more responsive to making sure that children who are identified as needing mental health care get those services. So this may not quite be, the same approach as what we've had in the past. Maybe we haven't been as diligent as we should have been, and so now's the opportunity that where there's an expectation that if there's been a gap in that expectation about making sure that children get those services, we're gonna narrow that gap. So the intent here is to ensure that kids receive treatment and appropriate care regardless of referral source. So it doesn't matter who's identified the child needs behavioral health services. It's considered a legitimate request regardless of who the source is, and that we would engage, again, when I say we, I'm talking Healthcare Authority and the managed care plan. We will engage in making sure that we acknowledge the request for services and that we support their access and assist in their achieving the goal of implementing that referral. We're going to, excuse me, folks, we're going to follow up to ensure appointments occur. We're going to coordinate with the PCPs, the primary care providers. We're going to make sure that clients are educated about the Washington Recovery Helpline, that we maintain adequate children's mental health provider capacity, and that we maintain accurate provider directories. Next page. So there's some required elements for implementation that include your policies and procedures. We must determine and respond appropriately to assist children who have been identified as requiring mental health services and treatment receive that necessary care. So we need to take more responsibility in coordinating the treatment and appropriate care based on that child's assessed needs, again, regardless of the referral source. We're going to follow up on and ensure an appointment was secured. We're going to coordinate with the primary care provider regarding the treatment plan, the medication management, and we're going to ensure patient confidentiality. So these are things that we would want to see in policies and procedures related to children's access to mental health services and treatment. Next page, please. So the required elements of the implementation include, as Colette laid out a couple months ago, is to make sure that the call center has desk-age scripts to respond to requests for children's services, and that staff have received training about how to respond to requests, the benefit coverage, how to access services by the managed care or the BHO, and that changes that are made in your policies and procedures have been, staff have been made aware of those changes and they have received training about those changes. So I'd like to hear from each plan in regards to what the status is on these training elements, these work deliverables or products to support your managed care plan's response to inquiries so that children and families are receiving the best service possible. So, AmeriGroup, can you respond? Raise your hand and we'll take you off mute.
Jennifer Carlisle from AmeriGroup.
No, she's from coordinated care, but if she's the first one to respond, I guess. Okay. Go ahead.
We'll do it in the order that we receive.
Okay.
Okay. So, Jennifer Carlisle. Go ahead, Jennifer.
Can you hear me?
Yep.
Yay. Okay, so we have a workflow developed and teams are in the process of being updated. We are going to be ready for a 1-1 go live. Our staff are in the process of being trained, and part of our workflows will include job aids.
Great. Thanks, Jen.
Next we have Kathleen Archer. Kathleen, you're up.
Oh, okay. So this is Kathleen. I'm you, and actually Tanya Niverson has the answer for that, and so she put her little hand up, but and mine's down. So can you call on Tanya?
Okay. Tanya, you are up.
Hi. Yes, we have already, we've written a policy to this effect and created a training and submitted it to our call center as well as the training. We've also trained our CM staff and UM staff and are on deck to train our outreach personnel here at AmeriGroup, Washington.
Great, thank you.
You're welcome.
Jolene Peebles.
Jolene?
Jolene Peebles.
Hi, this is Jolene from United Healthcare. We have a full project plan that does include the training rollout, policy and procedures, and the care coordination. And we don't have any barriers to implementation 1-1.
Great.
And looks like we have Gabriel. Gabriel, you're up.
Great. Yes, we're also green here at Community Health Plan, CHPW. We're on track as far as everyone who's provider-facing and member-facing to have the right education, talking points to this, and supporting it, making sure that it works. So that's good news. Full disclosure, though, I do look forward to just future collaborations and conversations on some of these operational points, such as ensuring that the appointment happened. We're always looking for better ways to do that, given the time lag with claims data and counter data and things like that. So maybe that could just be an ongoing conversation. But as far as provider directory points and other member materials, we are green. Thank you.
I believe that's it.
Okay. Lena, if you could drop me an email about those items, I would appreciate it.
Oh.
We
have Nadia Pickens from Molina. Bear with me one moment. Nadia, go ahead.
Hi, can you guys hear me?
Sure can.
We actually were here earlier with the prior question, but for some reason, you guys couldn't see that we were raising our hands. So, hi, everyone. So, yeah, we actually have been working on this. We have a behavioral health subcommittee, and we have been tackling this. So, we're excited about being ready to go live on January 1st.
Great. Thank you.
I believe that's it.
Okay. Next page. This specifically is around other issues such as the mental health webpage. Have you made sure that your website provides information and meets the needs of children seeking mental health services and their families? Have you added the Washington Recovery Helpline to your provider directory for children's mental health providers? And have you put information out there for your providers about the Washington Recovery Helpline? So, AmeriGroup or somebody, can you, plan by plan, can you respond to this, please?
So, Lonnie, are you available to respond to this? I'm going to go ahead and unmute you now.
Hi, can you hear me now?
Yeah.
Great. Okay. Hi. I believe that we've made this request so that we can get these numbers out forward-facing to providers. I can't speak to whether or not it's been completed yet, though, and I was hoping that Lonnie could answer that one.
Okay. I believe Lonnie is ready to go.
Oh, great.
Now can you hear me?
Yes, ma'am.
Can.
Okay. I've been trying to get myself unmuted here. So, what we need to do is talk with our provider relations staff to make sure this gets on the website. But I will send something out to them today. But I'm sure we can get something up by 1/1.
Great. That's what we care about. Thanks. Thank you both. Next caller. Or next hand.
Gabriel.
Gabe.
Hi, yes, we're good on this. We have the phone number posted on our website, and where it just says Washington Recovery Helpline and the 1-866 number. We also have a hyperlink for mental health resources, and that has how to find behavioral health specialists, has a link to our directory of clinics helping kids and teens, how to find a case manager, resources to our library, and then all this has been circulated with our call center too, so that they have that information. So that's up and live on our website. So that's up on our website currently live.
Thank you, Gabe.
Thank you.
You got now.
So Jennifer Carlisle.
Hey, Jen, are you on there?
Yes, hello, this is Jen. So our website's rolling out for integration in North Central, so I'm confident that for sure it will be, I don't know that we'll have a children's mental health website, but our children members will be covered. Our provider directory is also being evaluated. and I think config has already started it if it's not complete. I also know that I think through the collaborative MCO provider training that we just delivered as a group, we provided the information on the hotlines to the provider community there as well.
Great.
We're good to go.
Thanks, Jen. Next caller.
Looks like we'll have Kathleen Archer has her hand up. Kathleen, do you intend to have your hand up?
No, it's not. And it shows it's down. So nope. Yeah, this is not definitely Tanya's and Lonnie's on both of these.
Okay. Thank you very much. Krista Edmondson, are you ready?
Hello, this is Krista. Can you hear me?
Sure can. Hi, Krista.
Thank you. I know that our updates for our mental health website are well underway and on track for one implementation.
Great. Thank you.
Lonnie.
And then United?
Looks like that's it.
Okay. United, if you could drop me a line, let me know how you're doing on your website. I would be most grateful. Okay, so those items are things, those tasks that we just discussed are key essential for providing the information, again, that is expected of us and are seen as the legislature as being key elements to making sure that families have what they need so children can access mental health resources, which also includes the requirement on our part to follow up to make sure that they were successful in making an appointment. And Gabe, we could talk about that at the plan meeting in regards to options or feasibility or exactly how to accomplish that. And I appreciate all of the effort that you all have clearly made since leading the all plan meeting and going through this, and then you all had such great initiative to follow through and pursue this. That is terrific. I really want you to hear me say that I'm really, really pleased with that. So pat on the back to all of you. Second thing to talk about, or third thing to talk about, is the depression screening coverage. And this is kind of part of the Children's Mental Health Bill. It's a piece that we worked on last session. There was committees that met to decide or to recommend things to the legislature, interventions and initiatives that, again, would be helpful in supporting mental health services for kids. And depression screening was a topic that received a lot of interest. Depression screening for adolescents is on the Bright Futures guideline for treatments or services to be rendered during a well-child check. And y'all should appreciate the fact that we never before had any type of reimbursement or I'll say coding requirement for demonstrating that a provider actually provided the depression screening. But we're moving forward on 1/1/18 by saying we're going to follow those guidelines. And when children ages 10 through 20 are seen in a well-child check or by a PCP and the child is demonstrating symptoms or not demonstrating symptoms, to be perfectly honest, that provider can bill 96127 and receive and perform a depression screening of that child. Let's be aware of the fact that it's limited to usually one per year, but that would also allow for a limitation extension under our rules. So Medicaid would have a soft limit of one per year. A child may be screened and not be tested as being positive. The results might not be a positive result, meaning they might not demonstrate, or the depression screening might not confirm the child has depression, but the child may later present with such indicators and clinical signs and would therefore be screened, and a limitation extension would apply to the fact in that year that that child did present with some symptoms that needed further assessment, and therefore it was medically necessary, and so under limitation extension it would be allowed. Then in addition to that, we have coverage for what is usually y'all provided to the maternal parent, because women have a tendency to have postpartum depression after the birth of a child. I mean, that is a phenomenon that's unique to the individual who gives birth to the child because of the hormonal and other changes that occur after birth. But and sometimes it's just overwhelming to have a new child. But also to recognize that that depression can also occur in anyone who is the primary caregiver of a child. And therefore, the agency's policy will be that any caregiver who presents with signs of symptoms and has a child between 0 and 6 months of age would be candidate to receive a screen for depression. The code that one would bill is 96161, and it's unique in this particular service is that if the child's PCP is the person who identifies that the caregiver accompanying the child is the one who's demonstrating symptoms and needs to have this assessment, then that would be covered under the child's plan if the parent has no other coverage, if the child's PCP isn't enrolled with that parent's coverage, the child's MCO would be let's call it the backup, that you would be a viable payer for this service if it was rendered to the child by a provider who was enrolled with you. Again, limitation extensions may apply. It's possible that a child could be 8 months old, the caregiver presents with symptoms at the well child check, and the provider feels that they need to assess the caregiver's status by performing a depression screening. Now, not only are we going to cover these two services under the scenarios that I just described, but it's also we want to make sure that depression screenings are done with the highest of integrity or fidelity or quality. And therefore, we're going to use standardized tools. Now, I'll need to share with you that that the list of tools I'm going to show you at this point are still draft. There are a couple of us in the office working with community providers and a community stakeholder group to have input into finalizing the set of tools that we'll be recommending. But this gives you an opportunity to look at what's on the table for discussion. Potentially, maybe one of your CMOs might want to comment on it. We'd be happy to hear those comments. So we want to get some input from the community before we finalize it. But this kind of gives you a sense about the direction we're going. So Venus, can you go over to the Word documents? So this is a code matrix that we made up, created. We didn't just make it up. It's intended to provide you and any other reader an overview of what we're covering. And I'll share this with you. Now this is share with you that the folks working on this matrix have also included developmental screening. Now, developmental screening, you know, has been a covered service for quite some time, but because we're re-emphasizing the need to use standardized tools, I think that my colleagues over in the medical policy, the CQCT group, felt that it was an opportunity to re-emphasize and revisit the developmental screening tools as well. So you're going to see that code on this matrix because this document is the pivotal point to conversations and document decisions made. So can you scroll down? So 96110 for the developmental screening, and over on the, and that's in the left-hand column, and on the right-hand column, you'll see the billing requirements or the limitations, the types of claims that we pay, the places of services. There's a limitation total of 5 per lifetime per client, and then those tools are the screening, standardized testing, screening that's being discussed and being deliberated in terms of towards finalization for a final list. And you can read them there. And then if you can go on down, Dean, there's the 96127, which is the code to bill for the behavioral assessment, to do a depression inventory for the children, adolescents between the ages of 12 and up until their 21st birthday, as part of their well child check or other assessment. As I said before, it's not currently covered, but it will be on 1/1. We will be paying our professional practitioners, ARNPs, PAs, physicians for performing this service. The depression screening tools are there on the right as well. And then go on down, Dean. And then there's the 96161 code. This is where you're focusing on the caregiver. And again, it's because of the benefit for the patient in which the assessment is being rendered and determination and possible referrals to be made subsequent to that assessment. So therefore, it's a reimbursable service under the child's benefit. Again, we don't currently cover it, but we will 1/1. And there are no limits. Place of service, no limit. So this could also be done by the parent's PCP or the caregiver's PCP and be billed under the caregiver's provider, by the caregiver's provider and billed to you if the parent is covered under your plan. And then there are the depression screening tools that are in consideration to be potentially finalized on the list. And then we have this cool little matrix that Barb's worked on. And let's see, she said she wasn't quite done with this, I think, but this, I got draft on here, y'all. But it gives you a sense as to how we're laying this all out for future conversations with those stakeholders. The top ones, I believe, are about, looks to be about developmental screens. I can't quite see because that little thing is in the way. But you can see the codes there laid out. I like the way that she did that. I believe the free column is indicative of the fact that the tool is free. I think that is, you know, one of the issues around using a standardized screening tool for any of the 3 scenarios that are being presented, in that some of the tools are free and some of the tools cost the provider a license, I guess, so to speak, or every time use fee. You can see the list of instruments that she's looking at, the age to which they're applicable. And so this is the document that will be shared with our community stakeholder group. And again, if you want to share it with your CMO, feel free to do so. They might have comments that they would like to have contributed to the deliberation over finalizing this list.
Gail, we had a question. And the question is, the presentation indicated the adolescent screening is for age 10 to 20, and the matrix indicates age 12 to 20.
I thought it...
Which is correct, please?
Well, 12 to 20. So where did I get the 10 from? It's 12 through 20. I'll correct that on the thanks. So somewhere I was looking, sorry, it said 10. Not sure what my source was for that. But it's 12 through 20. You're right. Because actually I'm the one that fixed it on the matrix when it came out. Any other questions?
Gabriel has a question on 96161. Gabriel, we could unmute you if that works for you. All right, Gabriel, go ahead.
Yeah, so I have a compliment and then a question. So the compliment is for the caregiver. I see the good intentions of the caregiver not having any medical insurance whatsoever, but hey, this really needs to happen to make 96161 happen on the kiddos' insurance. So here are my two questions. One is, are there any concerns or thought as far as the integrity of the encounter data, such as will that infant now have caregiver's diagnosis of depression or something like that? So there's the encounter data piece, and then the second piece is just kind of like, and then what? So if this uninsured caregiver, gets this screening and needs follow-up services and maybe even a prescription, if the person has no insurance, is it true to say that we're only paying for their 96161? So those are my two-part questions.
Those are two great questions, Gabe. So first, I think that as a data analyst, I need to make sure to my fellow analysts that they understand that a 96161 that would be billed for a caregiver would be for a child who was 6 months, around 6 months, a maximum 6 months of age, and you wouldn't be actually screening a baby for depression. So it would be a code that was applicable to the caregiver. And it says clearly 96161 is a code that is specific to a caregiver. So anyone who's doing data analysis should know what the CPT codes represent and the fact that this is focused on not the person necessarily associated with the claim itself as the subscriber. Does that make sense?
That does make sense, and I'll have internal conversations with people who are a lot smarter than me. I just think that when we have Johnny member or whoever and has 10 encounters with 10 different diagnosis codes, and that kind of affects things like prison scores, sickness, population, stuff like that. But I guess I'll just talk to those folks and just make sure that they know that a 96161 doesn't necessarily make that infant quote unquote more sick, if you will. So thank you very much, Gail. And the second part is like, and now what for the caregiver? What are your thoughts on that?
So for now what, we're only the only assumptions here were the fact that you would be responsible financially for the screen. There was no assumptions in the fiscal note related to this bill around treatment for the caregiver that would be the responsibility of the managed care plan.
And this is Gabriel, and that makes clear sense from a finance standpoint, and I don't want to sound critical because this does seem like kind of a half step in the right direction, but it's clear to say that at this point an uninsured caregiver would get a screening, maybe a bunch of identified services and a prescription or something, but it doesn't look like there's any sort of financial or insurance coverage way for that person to get any services or prescriptions beyond that screening. Is that true just for now, Gail?
Well, to a point, remember that behavioral health organizations exist in every county, and where we are integrated, you have the behavioral health services being provided by Beacon for Crisis Intervention. And so there's still funding available through the mental health system in all counties that would see a client, do an assessment, determine if they met the criteria on which they would assume responsibility for using grant fund money or other funding sources that they have to cover behavioral health therapeutic services as well as write a script. And yeah, the prescription probably wouldn't be covered, but at least the person would have access to services if they met certain criteria. And the behavioral health organization or the managed care plan responsible for those particular services were so inclined to provide service. Does that make sense?
Yeah, absolutely. So with the uninsured caregiver situation, it could be such that they're not on Apple Health, but then they get the screening tool, and then just where we are right now in state of affairs is that just hopefully there would be some other funding source or some other aspect of the safety net that's somehow getting this person something beyond the screening.
Yeah.
Okay.
Yeah.
Thank you very much.
And then possibly the question is are they eligible for Medicaid? And then they just need to apply. So the individual that they connect with, you know, for example, the BHO or the I'm going to call them the managed care crisis plan would help them connect with Medicaid if they met the eligibility criteria as well.
That's a good point. Maybe this is the trigger for them to investigate whether or not they do qualify. So thank you.
Right.
Thank you for talking us through that.
Yeah, I think in regards to data, Gabe, you just have to be sure that people know what that code represents, and depending on what question they're asking the data, they either take it out of the query or they figure out how to use it. But you know, it's like anybody who does data analysis, you got to know what's in front of you when you pull something and what to take out or what you want to purposefully leave out, and work with a programmer to write the query in a way that answers the question you want to ask.
Okay, Jen Carlisle has a question. Jen, you're unmuted now.
Thank you.
Hi, Gail. It's Katie.
Hey, Kate.
Who qualifies as a caregiver?
Well, it was anybody who was primarily responsible for the child.
Okay, so
could be the father, could be the grandmother, whoever is primarily.
Not a babysitter that brings the kid in for a well child visit.
No.
And not a foster care caregiver.
Yeah.
We're assuming.
Say again?
Not a foster parent.
It could be a foster parent.
Okay,
it could be the foster parent.
Okay. So they provide primary care for the child.
Yep, they're the primary care provider for that child. Could be an aunt.
Could be you, Gail.
Could be, but I don't think so.
All right, we have a couple of other questions. Katie, do you have any other on that topic? Okay. So Leona, on our team brought up a point about the medical records. Leona, can you?
So one of the requirements there was that it was documented in the medical record, but if it's a pediatrician's office, are you asking them to document it on the infant's medical record?
There would be a note provided that said that it was identified that the caregiver accompanying the child was demonstrating that they had clinical indications for which a depression inventory was indicated.
Okay. So on the child's record or the infant's record?
Yep.
Okay.
Because you see, understand this, when we go to, if we were ever audited, we wouldn't know that person's name, and we would be pulling that child's chart in order to confirm the assessment and the screening was done.
Right.
So, Gail, this is Jen again.
Because the chart you pull has to match the name on the bill.
Right.
So I think that's related to my question, which I think you've already covered, but I'm just processing through this. So on an encounters and we would be submitting the encounters on baby's ID.
Right.
Okay. My last question is related to, this is all going live 1/1, correct?
Yes, ma'am.
So we're going to get into a pinch in terms of config if we don't get final guidance from you guys as soon as possible. Do you have an ETA when this will not be a draft anymore and when we might receive it?
Well, the only part that's in draft, kiddo, is this actual screens. The policy itself is final.
Okay. Okay, and you're gonna when will you send that out, or have you already?
Venus will send it out when we're done here.
Great, thanks, Venus. Sorry, I said it was my last question, but I actually have more. In terms of the screenings that have already been identified, if we were to identify additional screenings to be added, is HCA open to input, or is this a final list? This is the end of the conversation.
No, I think if you have contributions you want to make to the screening tool matrix I sent out that's marked Appendix A, you should submit them with your 3 statements of justification, and we'll pass them on to Barb.
Awesome. Okay, and then last, I think this is really truly the last question. When will the fee schedules get updated with this info?
In December.
Do you know when in December?
But I sent no, probably towards the middle to end. I sent the rates in the email that I sent out with the invitation.
Yeah, I saw that. We were just looking for more formal documentation. All right.
Oh, okay, I get it.
Joe Ellen Peebles has a question. Joe Ellen, you've been unmuted.
Hi, this is Jolene. I was actually had my hand up earlier to report out on the website. So that it wasn't a question to this. I was just reporting on that.
For United?
So, yeah, for United. I wasn't called, but my hand was up. So I should have taken it down since we were. We included both of those website requirements on our project plan for the mental health for children. So we are expecting to implement by 1/1/18.
Great. Thank you. Thank you. So, Jen, I will check with Wendy and see when she will be posting formally the rates for the screens.
Valerie, do you have a question?
No.
Okay.
Okay. So the things to go on to the next screen then. This is complicated, you guys, because we have to go from PowerPoint to Word and back to PowerPoint. It's a new skill set. Yep. So the things I was thinking that you all would need to take into account for implementation of the depression screening would be system changes, adding coverage of the codes, making sure that you identified the whatever's required in order to pay for the 96161 code. I think I said that correctly, for the caregiver. Yep, 96161 for the covered child. And then provider education. I think it's important that we let providers know that this depression screening is now covered. I don't know about y'all, but some of you have been working on the Well Child Initiative. And what I hear when I talk to providers about Well Child and the Bright Future Guidelines, you know, is that this state, this agency, doesn't pay individually for all the services that are listed on the Bright Futures Guideline and are expected to be provided as services to children during a well child check. And so it's a good opportunity to say to providers, you know, the legislature has recognized the need for funding for this code. It's not a lot. It's based on our usual reimbursement policy decisions in regards to how we derive our rate. But it's still being broken out now, and there will still be some additional funding available for performing this depression screening for children between the ages of 12 and 21, or up to the 21st birthday. It's also important then to make sure that providers know that the maternal screening, the caregiver screening, is now a covered service. This is going to be a big change for provider offices to know that they now can have an opportunity to do the depression inventory on the caregiver and to make appropriate referrals, and that there will be some level of reimbursement for that. It demonstrates the intent of the legislature to try to improve the mental health of the child, as well as an adolescent child, as well as the caregiver of a newborn baby, and to make that environment more positive for that newborn baby. And then, of course, there's an opportunity for client education. So it's important that the clients know that they have coverage, families of children who are adolescents, that they can have their child screened, that a parent who may be worried about how they may be feeling after the birth of a child, not necessarily knowing where to turn. They're on your website. They're looking for, for resources or ideas, providing some education to them as well to say that this is now a covered service and this is how it could be paid. I think it's very important so that people can be prompted to take the initiative and seek services that they may not readily seek without that little bit of prompting. Okay. Any questions? Raise your hand. Going once? Going twice? All right. Well, let's move on to the two bigger reasons why we're here today in terms of the fact that they're going to take more time. Okay. We're going to talk today about the collaborative care model. We're going to begin to cover collaborative care. Now, I'm hoping that y'all have some fundamental understanding of collaborative care. I am sure that there are some of you on the phone who probably know more about this than I do. But I'm on the committee here to implement this, and it's been an interesting learning experience. Some of you may have participated in phone calls that I have also participated on. So, did I really spell that wrong? Nope, I did not. That's what happens when you take your glasses off. So let's just begin with an overview. And I'm sorry if I bore you because you already know, but I need to make sure that we're all coming at it from the same perspective. So the only way I can ensure that we do that is if I take the time to do some quick review. So understanding that, again, the legislature and this agency is very, very focused on behavioral health, primary care, physical health integration. One of the measures that we are taking to achieve our ultimate goal for integration is covering this collaborative care model. The legislature, in the end of the budget this session, gave us money and asked us to begin to cover the codes that have been specifically identified and associated with the collaborative care model. So this is a specific component of behavioral health integration, and the model was developed at the University of Washington. So the University of Washington is consulting with us and helping us to implement it as a payer. They are also consulting with other Medicaids in other states to implement this model both for Medicaid and for commercial coverage. So the University of Washington has a whole section devoted on implementing this program. The idea of this model is that it is designed to support PCP management of conditions such as depression or anxiety that require a systematic follow-up. There is coverage for qualified medical providers to provide these collaborative care services. And we're going to talk about who's qualified in a few minutes. This program requires tracking of clients in a registry and the delivery of measurement-based practices and treatment that are targeted. It provides case management and regular psychiatric interspecialty consultations to the primary care team. And it assumes that it would approximately provide, the length of coverage would be about 4 months, that a person would be enrolled or have an episode of care that would last about 4 months, but that it could be provided for actually up to 12 months and maybe more on a case-by-case basis. If more intensive services are required or treatment goal is not achieved, a referral to a behavioral health professional should be made. So in other words, we're talking about a model that supports the primary care provider in addressing the client's needs, providing treatment, but also recognizing by working with a psychiatrist when the need for that care may need to be escalated to a different provider, or when the care that the PCP is providing may need to be changed based on a reassessment. And again, it's like tried and failed. If it's not working, change it. That doesn't work, then when do you need to make a referral to a behavioral health provider? So let's go on to talk about that word qualified. So the University of Washington's created this model, and they have very specific expectations as to what the model entails. So it's important for you to hear me say that people who are not providing care consistent with this model cannot be reimbursed for this service. You have to be kind of a center of excellence for collaborative care. And you have to be designated as being someone who is providing care consistent with this model. The University of Washington is currently training providers in this state as to how to provide services under this model. So this is an active process that has already been implemented, for which we're now going to pay. So a qualified provider could be a clinic or an individual provider, and they must attest to providing this service consistent with the approved collaborative care model. The delivery so the essential elements of that are delivering care in a patient-centered team focus. The primary care and the behavioral health providers should be collaborating effectively using a shared care plan with patient goals. It should have a team structure, and the model should include a treating provider who's usually a PCP, but it could actually be another type of provider. For example, if I have cancer and my primary care provider at this time is an oncologist may make a referral or involve me in his collaborative care model, because oncology, as you know, is fairly intensive, long-going, and the relationship that that client may have with that provider may be one that is with frequent follow-ups, and that provider may be helping me to address any behavioral health issues that I may be exhibiting related to my oncology treatment. The team structure also has to include a behavioral health care manager. So this is actually a person or provider who has specialized behavioral health training working under the oversight of the treating provider. And in most models, this person is a social worker or a nurse. It could be a psychologist, but this person is what we would call our behavioral care health care manager. This person is actually the coordinator who is providing the case management and seeking the services of that next team member, which is the psychiatrist. And of course, this is an MD, and this person must be qualified to prescribe, because that could be an outcome of the consult. And then, of course, the client, the patient, would be actively engaged in this team structure approach to the collaborative care model. Another component of the collaborative care model is the frequency of care. One would expect a person to be seen at least monthly for an episode of care that usually ends when the targeted treatment goals are met. But it could also end if there's failure to meet the goals, which results in a referral for direct behavioral health services, or there could actually be a break in the episode, which is defined as when a person and the care manager have not connected for at least 6 months. It's important that the collaborative care model include a measurement-based treatment target, that the treatment plan has personal goals and clinical outcomes that are routinely measured by evidence-based tools. And treatment is actively changed if there's no improvement, until clinical goals are achieved. So in other words, you would be assessing a client's response to the intervention that you initiate. Client doesn't respond, you would engage with the psychiatrist. He would modify the treatment approach. You would initiate that. There'd be an assessment of patient's response. If the patient didn't respond, then you would be again conferring with the psychiatrist. Now notice that I say conferring because the psychiatrist does not have to see the client. The psychiatrist is available to be there as a telephone consult or for the two docs to talk, or the care manager to talk with the physician, but it does not require a face-to-face consult with that psychiatrist. That's why you need someone who's really skilled in the other side of that conversation, understanding what information needs to be relayed and how to interpret what has been data that's been captured. So the psychiatrist has a very clear clinical picture. And then the last component of the collaborative care model is that there needs to be accountable care and a registry. That the registry tracks program enrollment and the patient's clinical outcomes to support quality of care. And the registry is actually a tool that the University of Washington has created and shares with providers so that they can bring that program up using something that, an application that's been developed and tested and is conducive. They don't have to start from scratch, which is kind of cool. So now I want to show you some little tools. This is the attestation for collaborative care. It's going to be on the HCA website. Now, this will be managed by my colleagues over in the CQCT group. But we're going to send something out to providers telling them that they can access this attestation, where to get it out on the website, and that they can submit it for review. And then someone in CQCT will look at this and decide whether or not the patient is, the provider is actually providing services consistent with the model, and that they have a test that they have had the appropriate training that I referred to earlier being provided by the University of Washington, and that they are using the tools and the key principles to rendering these services. Now, what I have worked out with CQCT is that when they receive one of these, we are going to indicate on our provider enrollment file here within the agency that a provider has been approved to be a collaborative care model provider. And when they send that email to provider enrollment, they're also going to send an email to the managed care inbox, which means it will then be forwarded to you all. So my message to y'all is that you're going to be receiving these emails, and you're going to want to develop a process that you receive these emails and that the people who need to know are made aware of this form, receive this form, and can take whatever action your company requires, your organization requires, to make sure that you know what providers have been approved to bill for these codes because they're rendering services consistent with this model. Would also offer to you, though, that you all also contract with individuals for whom we may not. And so the question you all need to think about and to expand access to this service is how you yourselves may have providers attest that they're providing services consistent with this model and can be approved to bill for these codes. You may want to use this form. We don't have any type of license on it, but I would suggest to you that you want to expand your network to provide services that are consistent with this model. So I offer that to you all as something you need to look at to further, in regards to further implementation of this program.
Gabe has a question about is psychiatry always MD or can it be an ARNP?
It's supposed to be an MD, but I'll check on that. I'll check on that.
And then Krista is asking, if the provider has a core provider agreement with HCA, can they follow HCA's process to submit the attestation form?
Yeah. Yeah.
Here we have one more.
And then I also have that nice little matrix document that's applicable to this particular component of the behavioral health program, the integrated program that we're implementing. Talks a little bit about collaborative care there. And then it lays out the codes that I sent you in the email. Thanks, Dee. So let's just review them for a second because I think it's important that we all understand them. The 99492 code is the initial psychiatric collaborative care management that is for the first 70 minutes in a calendar year in which the team is interacting with the client. So what's important here to know is that all of those 70 minutes are not spent face-to-face. This is about care management, and those of you who have been involved in care management know that a lot of time is spent without being face-to-face when you're trying to manage someone's care. The patient is not always in the room with you. There's a lot of coordination, a lot of contacts, a lot of documentation, reviewing documents itself, interpreting information. Those things are now billable under these codes. So you can see the items there that are laid out in the bullets to help provide some definition around what's occurring within those 70 minutes. I think the one thing that we have found that we're working with providers to implement this that is a challenge is how to get those 70 minutes documented. And so if people have EHRs or even a paper format, there has to be documentation of start time, end time, total time spent, and someone has to be responsible for recognizing that 70 minutes has been provided and it's time to fill this initial code. Because 70 minutes can occur over a matter of days, weeks. And so there has to be a tracking system that supports billing. And what we found is that some providers weren't billing it because they didn't have a person who was, let's say, on point for determining that the 70 minutes was spent and therefore, or had been accumulated, and therefore they had a billable service.
Krista Edmondson has a question about non-billing agreement.
Okay.
I wondered if you'd be available. Krista, go ahead and ask your question if you could. You're unmuted now.
Sure. Gail, you had mentioned that NCOs may need to consider a process if there's a provider contracted with us, it's not contracted with HCA. But as long as it's a non-billing agreement with HCA, could they go through HCA's process attestation?
I doubt if someone who's non-billing will, Krista. I doubt actually if they would, because there's no real reason to do it specifically with us, because we're not. Okay. They're not going to bill us.
Okay.
Unless
so we'll work.
Unless they decide to change their status.
Okay. Thanks, Gail.
No, just notice that under provider type, when we're talking about who this is billable by, this particular service, as we talked before, is billable by the medical provider, usually the PCP. That medical provider includes MDs, DOs, NPs, naturopaths, ARNPs. So pretty much the full spectrum of a provider there that one would assume would be in a primary care or physical delivery model. So 99492 is a code that you can bill once in the first calendar year for the initial psychiatric collaboration, implementation of this model. Then the second code then, for subsequent 60-minute intervals, is the 99493. The required elements are laid out there for you, same type of provider, MD or a clinic or ARNP, DO, NP, and this code is billed once per month, subsequent calendar months to the initial. So you have to have the initial, and then you can bill the 99493 for every 60 minutes in the subsequent month. It's important to note when you look over at limitations on this document under the 99493 on the right-hand column is that it says it's billable once a month, but the patients must have one face-to-face at least every 3 months. So that means that I may be, as a provider, may be billing 60 months this month, or 60 minutes this month. I had my initial last month. 60 minutes this month, 60 minutes next month, 60 minutes the month after that, but I need to be having a face-to-face next month because I need to have a face-to-face encounter as a care manager or a PCP with that client at least every 3 months. And I will share this with you. Notice that it says if they haven't had a face-to-face within a 3-month period, the process will need to begin again with the initial code of 99492. And what I told you earlier was that an interruption in an episode was 6 months long. We're checking with the University of Washington because there's a different scenario there of 3 months requiring a face-to-face and not having and start over, and then say you can have a 6-month period where you don't have any interactions and now you start over. So we're trying to get clarity from the UW exactly what they're trying to say there, and I'll share that with you as soon as we get that clarity. The rates on this page come directly from the rates person, Wendy. They've all been derived, and you will note that they are higher than what you may anticipate seeing. These rates are based on CMS, Medicare, I should say. Then if you go to the third page, you will see a 99494. This is a code for an initial or subsequent psychiatric collaborative care management with each additional 30 minutes in a calendar month. So you can bill the 99493 for the first 60 minutes, and then you get a add-on 99494 for additional 30 minutes. And there's really nothing more to say about what's in front of you for clarity. It's pretty straightforward. And then the last code I want to point out to you, because this is important, this is where you're going to have to figure out how your systems are configured. The codes that we just went through, those 9,000 codes, they cannot be billed by an FQHC or an RHC. Medicare has adopted a different code for services rendered by an FQHC or an RHC, and we're going to follow their policy. And that is the use of the G0512 code. It is the only code they bill. It represents 60 minutes. Services still have to be rendered by a primary care or medical provider, an NP, DO, or ARNP. But the key here is it is for any and all services rendered in an FQHC or an RHC. So you do not want to have non-FQHCs or RHCs bill in this code. And you don't want to have FQHCs or RHCs bill in any of the 3.9 codes that I gave you. Any questions about that?
Looks like we have a hand up from Alan Fisher. Alan, you had your hand.
Hi.
Go ahead.
Hi. So I had two quick questions. One, does the FQHC or RHC need the same qualification as any other provider billing the collaborative care codes? And then the second question is, this is a great document. Will all of this at some point transfer into one of the standard billing guides?
Yeah, very good. Okay, so Alan, yes, an FQHC and an RHC has to be attested and certified to be rendering care consistent with the motto as defined. And something very similar to this, yes, will be in the billing guide.
Great, thank you.
So let me just take a moment about that. It's my understanding that my colleagues in CQCT are developing a specific guide to promote behavioral health integration. And the reason why you guys y'all see this phase 3, phase 4 code matrix, believe it or not, there's also a 1 or 2. I know you may find that hard to believe given that this is 3 and 4. But there's a 1 and 2 as well. And these are all subcomponents of the information that will be in that billing guide and designated as a behavioral health integrated guide, so that it addresses services that can be rendered on the primary care side of the house and services that can be rendered on the behavioral health side of the house, and without limitations, without setting constraints, so that we can make sure that providers are knowledgeable about how to provide behavioral health integrated services and receive reimbursement from those. So that's a little bit of the big picture. Does that help, Alan?
It does. Thank you very much.
Yeah.
Jen has a question.
Hey, Jen. You only have one?
She might have a couple.
I bet she does.
Funny.
We got your number.
Yes, you do. I'm wondering, and I think you've covered this again, but I'm just wanting to make sure that we understand. In terms of knowing which providers, can you restate what you said about providers? I'm wondering if there's a way that HCA could collect this data. I'm a little confused on whether we're expected to. There was a form that you had up for a minute about providers registering. I was wondering if that's something that could be included on the NPI report that we received from you as another data element.
You mean, is it the indicator for what providers have been approved to be a COCM?
Yes.
Yeah. I don't think it can be included in that report. I do not believe that. I will check, but I don't believe that that report captures the indicator field that would be marked on the provider reference file.
Okay, so we're operating with an attestation that would have to go into the credentialing file and that kind of thing. Okay. And then, yeah.
Well, we're going to send you an email that tells you when someone who's already enrolled with us and potentially with you all has submitted the form and been approved to have this status.
Okay, that's the part that I missed. So is that going to just come through the mailbox? Is there a more efficient way to do it?
Well, I thought that was efficient because they're going to have to send it. They're going to have to send an email to provider enrollment, and it starts one place and goes out to two. You're downstream from that.
Yeah, I won't speak for the other MCOs, but I'm wondering if there might be a more streamlined solution. But for now, sounds great. Thanks for sending us the info.
Yeah, it's a matter, I mean, what I was trying to think of is what I could get to you real time, given the fact that we've got about 15 days to identify these people and get them, get whatever you all need to do with that information so that you can pay them for these codes.
So maybe it's more that I have a question about the upfront, like we might want to know in the first 15 days, but what about in an ongoing? Sorry.
Well, I can, you're echoing, dear.
I know.
So I'll tell you what, I'll check to see if the NPI list that we send out, if there's any way to capture that indicator, because I'm not sure there is, Jen. I haven't actually checked into it.
Okay, thanks for looking into it.
Oh yeah, no problem. We'll look into that.
Julie Lindbergh has a question.
Hi, Julie. Can you hear me okay?
Yes, ma'am.
Great. A couple questions. One, I anticipate with the attestation or any other question, we'll get questions around fidelity to the collaborative care model. Did you all consider whether or not there's some threshold of fidelity?
We did. Basically, the provider is attesting to the fact that they will be qualified to do this and that they will be subject to audit and complete recovery of the money spent if we do a chart review.
Okay. So say, for example, someone says they use the collaborative care principles, but they haven't been formally trained by the AIM Center, let's say. That's up to them to attest that they have the qualifications to use the codes.
Yeah, well, actually, if you notice what it says is, I have received and reviewed the COCM guidelines, understand them, have received training and implemented the COCM consistent with said guidelines and agree to comply with said guidelines. So that's the attestation they're signing that says that they've received the training and they're implementing something that is consistent with the University of Washington's training and guidelines.
Okay. Thank you. And then second question, I noticed that you're using the 9,000 codes or 9,000, the 9 codes for non-FQHC. What was the rationale behind using those codes as opposed to the G codes?
Good question. And that would be a question that we didn't get an answer from Medicare on. We pondered that question ourselves. I do believe, let's see, one lady from the University of Washington that we talked with says that she too was curious and she asked Medicare about it. And the reason being is that Medicare, like us, pay the FQHCs and the RHCs in a different reimbursement methodology, and they felt that deriving one payment using one code for those two specific centers based on an average of the codes based on an average reimbursement that they pay for those, for services in those two settings was the best way to go, and it required a unique identifier.
Sounds reasonable. The one thing part of where my questioning is going is I had a conversation with a provider a few months ago around using the ESPER codes because they were doing screening and brief intervention for alcohol use, but they said they didn't use the codes because they had tried to use them, but what they found is a lot of commercial plans don't cover the codes. So when they were using the codes routinely as part of their workflow, commercial patients were getting bills to cover the service that they had to pay out of pocket because their plan wasn't covering it, and they were getting a lot of complaints about that because it was not something that they had gone in for or asked for. And so I'm just wondering if we're going to face the same issue with these collaborative care codes. I was wondering the same thing with the depression screening code as well. So I don't know if that came up at all in any of the work group discussions.
No, none of the providers have talked about that. Actually, the group that I was telling you about that has the phase 1, phase 2 matrix, the expert codes are actually on that because they're part of behavioral integration. So they're on that other committee's list of proposed codes. These codes are very specifically designated for collaborative care. They've been in use for several years, actually. I'm going to say like since 2010, maybe more recently. But these codes should be, if the commercial carriers are covering case management, these are codes that they would be paying for. And if Medicare is paying for them, most carriers follow suit. So hopefully everybody will get on board.
Yeah. Okay, thank you.
Mm-hmm. Yeah, these aren't actually new codes. They've actually been in place for a while. We just usually don't cover this type of service, and now the legislature has funded us to do so as part of the new behavioral health integration model. Okay, any other questions?
Yes, Gabe has one. Does the HCA have a specific provider training in mind, i.e. any training through AIMS Center?
Well, I don't know about AIMS Center, but I know that, Gabe, that's a really good question. We are talking about training, and we're talking about collaborating with the University of Washington to provide that training because they're the experts. So there are some webinars potential being discussed to provide training to providers so that providers can take that initiative and move forward.
Ellen Fisher, you have a question?
Hi, me again. So is the RHC code, the G0512, included in the encounter rate for the RHC? We're looking at we're looking at the WAC, and it could be considered under the family that the WAC includes.
No, let me quote the FQHC program manager when I say this. No.
Long quote.
It's not encounter eligible.
Okay.
And it's because you're welcome. And I'm glad you asked that question. Yeah, all they get is the 134.38 for this code.
Yeah, just it may be worth at some point a clarification in the RHC billing guide, because I could kind of read it either way. I definitely heard the one-word answer though.
Yeah, well, and let me just share with you the reason. The reason is because it requires a code that is encounter eligible always requires a face-to-face, and this does not. So for Medina, that was the pivotal decision-making point.
That makes sense.
Okie doke?
Yep, thanks.
You're welcome. Thanks for asking.
Gabe has a question.
Gabe?
One moment, let's unmute Gabe.
Gabe?
We may have lost Gabe in the webinar function, but his question was, Oh, he says he's here. Oh, he's muted. No question. He says he's good.
Okay.
Thank you.
Guys, we got about 25 minutes, so I got to keep moving. So let's go to the next slide of the collaborative care model. Payments, again, are based on services provided by all team members. Although the psychiatrist may provide a face-to-face consult, and if that is has been provided, if that has been rendered, then that service may be billed separately using an appropriate E&M, because his face-to-face consult is not assumed in the reimbursement for those codes. Next thing to go on to is things that you need to think about in regards to implementation or system changes. Add these codes with the defined limitations that are in the handout I gave you. Identifying qualified providers, I've already explained that beginning 12/15 we'll be receiving the attestations, and the output of that to you all will be a message through the mailbox about who's been approved. And then I would offer to you that educating your providers will expand services and hopefully improve quality of care provided to clients who participate in this program. All right, last element to talk about, potentially preventable readmission policy. So hopefully your provider, your CMOs, and some of the other folks on your staff have been coming back and talking to you all about implementing the next generation of the readmission policy. So let's run through the policy and things that you're going to need to know. And I'm adding this, I want to add this to the webinar because I feel obligated to make sure that those of you who operationalize your UR programs, that we should have some time to talk about this. So the idea here is that we're going to return to individual case review. You may remember that we went to a reimbursement methodology driven program, I believe January of 16, and we reduced the rates for hospitals based on their readmission ratios, and that was derived through looking at all of their claims data, and a contracted vendor did that analysis and made recommendations to us in regards to how their reimbursement should reflect their previous year's readmission rate. You all know that many of you as plans were not happy with that. Some of the hospitals weren't happy with that. So we're going to remove the previous policy that was in place that I just described, and we're going to return to individual case review. But it's going to have some changes. We're going to all try to follow a common policy, MCOs and fee-for-service, because one of the complaints we heard from the hospitals was the differences in the programs made it difficult for them to manage. We're going to provide specificity around the provider role in discharge and follow-up planning. There are certain conditions that are going to be excluded, and the determination and the recoupment must be retroactive, so after you've paid the claim. This is not a pre-claim payment process. This applies to medically necessary admissions because, as the parens say, medically unnecessary care would be denied based on medical necessity rather than the status of being a readmission. So it's different. When you look at a claim, you're looking for something, you're looking for medical necessity. If you've deemed it's not medically necessary, then you're going to deny it for med death and failure to achieve med death. You're not going to deny it because it was a readmission policy subject to this policy, or a readmission subject to this policy. Critical access hospitals will be excluded. Okay, so down to the nitty-gritty of the policy. Readmission reviews will be applicable to admissions that occur within 14 days of discharge from a clinically related index admission. A readmission is considered to be preventable if there was a reasonable expectation that it could have been prevented by one or more of the following situations. The provision of quality of care in the index hospitalization or the initial hospitalization was identified, and that resulted in the readmission. That could have been prevented if better care had been provided in the first admission. If there was inadequate discharge planning, or if there was inadequate post-discharge follow-up. So those are the scenarios in which you have a preventable admission, and by providing effective discharge planning and adequate post-discharge follow-up and care during the first initial hospitalization, it could have been prevented. Then there's a note there that is important to recognize, is that if issues with quality of care, discharge planning, or follow-up occurred but cannot be reasonably considered the cause of the readmission, payment cannot be denied. So when you're looking at your records, you have to think about it from the standpoint of that it was not reasonable to consider that one of those three issues, or more of those issues, one or more of those issues, resulted in the cause of the readmission. Now, some admissions are excluded from consideration of this policy. Let's review what those are. One would be the readmission for reasons unrelated to the condition or care from the initial admission. Well, that makes sense, doesn't it? Because that's not really a readmission if it's not related. So it's not subject to a readmission policy. Or it is a planned readmission. So some examples of that are when you have repetitive treatments such as chemotherapy, transfusions for chronic anemia, burn therapy, dialysis that requires inpatient status, or some other planned treatment for renal failure. Situations where you have planned therapeutic or procedural admissions following a diagnostic admission when the therapeutic treatment clinically could not occur during the same case. So there's also those situations where you have a client that has been in an accident, there's significant swelling around the fractured extremity. You're going to discharge the client from their inpatient status and let the swelling go down, and then bring the client back to do additional pinning or fracture stabilization. There's also the scenario where you have the individual who presents with a gallbladder issue, and you're going to do IV antibiotics and calm the gallbladder down before you actually go in and remove it. So those are the types of scenarios in which we're talking about, things that you know can't be separated, have to be separated into two different courses of admission related to treatment of the same condition, but to provide the services in one admission is not best practice. The other scenario is where you have a same-day planned admission to a different hospital unit for continuing care. So that's pretty simple. That's a situation where a client went from a medical bed to a mental health bed, a chemical dependency transfer, you know that there's the rehab transfers that occur after a medical admission. So those types of scenarios are not considered readmissions. Patient is changing site in order to continue care related to that original admission. Other exclusions include when the treatment is required for cancer. Required treatments for cancer, including treatment-related toxicities or care for advanced stage cancer, end-of-life or hospice care, patients who left AMA from the initial admission and now present again. When a readmission is due to the patient's non-adherence to the discharge plan despite appropriate discharge planning and supports. This also includes cases where the recommended discharge plan was refused by the patient and a less appropriate alternative was made to accommodate the patient's preferences. This must be clearly documented in the record so that the reviewer understands the situation. Obstetrical readmissions for birth after an antepartum admission. Admissions with a primary diagnosis of mental health or SUD. Neonatal readmissions, transplant readmissions within 180 days of the transplant, and readmissions when the initial or index admission occurred in a different hospital system. So that reviews situations where when you're reviewing a claim, you look to see if one of those are applicable. If it is, then it is excluded from this policy and the claim is appropriate for payment. There's no need to review anything further. Now, for those readmissions that don't meet the exclusion criteria and were medically and aren't a situation where it wasn't medically necessary, you want to recognize the provider's responsibility for the discharge. What do we expect a provider to do? And did the provider do what was expected? So in order to be clear with all providers as to what the expectations are in their role of discharge planning, this policy articulates that. They're responsible for the discharge summary. And I'm not going to read all that to you in the presence of time. So I think it's pretty clear in regards to what they must document. The patient needs to be given all required prescriptions and educated on the appropriate use. The discharge instructions provided must be explained, given to the patient prior to discharge in a linguistically appropriate format, and if written instructions cannot be provided in the patient's language, there should be documentation that oral instructions were given by a translator and the patient's questions were fully addressed. So in other words, making sure that that client was discharged in an informed scenario of care in which they knew what to expect with their discharge, what to identify, how to respond if they were having problems post-discharge, when to contact the provider, how to take their meds, and so forth. They also should be given appropriate contact telephone numbers so that the patient has someone to call in case they have questions. The following should also be arranged by the provider. Follow-up appointments that are scheduled in an appropriate time frame, DME if it's indicated, placement and other relevant financial and social needs of the patient have been identified, and efforts are made to address these. If for the above three categories barriers are encountered, including access, availability, authorization, or payment, the provider's responsibility is to clearly notify the MCO of these needs and barriers and partner with the MCO to address these issues. The provider must clearly document, when a provider contacts the MCO, they have to clearly document the format and the content of the discussion with the MCO and the clear communication of the patient's needs. A voicemail without follow-up would typically not be considered adequate notification. Requests from providers for assistance with addressing barriers to post-discharge care must be separately identifiable from general utilization management and medical records. The provider should notify the MCO of the planned discharge and the anticipated needs sufficiently in advance of discharge to allow follow-up to be arranged and provide documentation needed to support authorizations. If a readmission occurs and the gap of care is due to the MCO denying recommended follow-up care, then payment cannot be denied for the readmission under this policy. Any comment about that, y'all? I was looking for a way. Nope. They don't want to go to. All right. So, managed care organizations are expected to offer the appeal and dispute process. You must offer at least 2 internal processes for confirming the determination that the readmission was preventable under the policy. One level would be a reconsideration request, and another would be the formal re-review. Then there was concern from the stakeholder group, which of course consisted of hospitals and plan representatives, which most of the time was someone from your CMO office, that there might be a situation where there was an impasse reached between the plan and the hospitals felt they needed to have another mechanism for intervention. So, under the provisions of our responsibilities for contract oversight, my section will provide a process, a dispute resolution process. The provider can submit a request for review with their position about the clinical situation and supporting clinical documentation. We will review the information provided, and we will make a determination based on the information submitted. I should also say that when we get a review, we'll reach out to you all and ask you to submit information that you think is pertinent to supporting your position about the continued denial, even after it's been through the 2 levels, or that was considered in the 2 levels, so that we'll have your position as well. Another way that we will monitor MCO adherence to the policy is through our contract monitoring and auditing process. Actually, I believe it's more about team monitoring. So I took some information from a slide that was prepared by one of the members of our CMO to do this. So, so it's actually going to be, we'll look at it through team monitoring. We'll probably pull some cases for which they were readmissions and where denials were upheld, and so we'll review those cases as an sample of the outputs of that work. And then the third option for contract oversight and dispute resolution is a hospital can ask us to review an MCO's potentially preventable readmission practices if there's concern for a pattern of inappropriate adjudication. So there are 3 different levels there: a case-specific level, a level that's done through team monitoring as part of our usual and customary contract oversight and adherence responsibilities, and then a hospital triggering a review based on a concern of a pattern. Some other information that might be important to share with you to implement this policy: MCOs cannot deny payment prospectively based on the policy. Previously talked about that. Determination of provider preventability must be done in a post-payment review, and payment can then be recouped if appropriate. The MCOs will work with HCA to develop standardized approaches to implementing this policy, so that process is standardized across the MCOs. And I foresee that that work is yet to be done, or we'll be figuring that out. I'll be working with Emily on how we're going to do that, y'all. Maybe we'll do some type of case reviews, I don't know. And then lastly, if any communication with the patient is needed, which is not to be expected because these cases don't involve a decision based on medical necessity, these are contractual provider MCO issues, not patient issues. It must be made clear to the patient they're not financially liable for the cost of a PPR admission. And that is that. Any questions about implementing the new readmission policy and identifying a potentially preventable readmission?
Going once?
Seriously, guys?
Going twice?
I think they're just tired of listening to you.
Yeah. Good thing I'm not a preacher, huh?
Lonnie has a question.
Go ahead, Lonnie.
Hi, Gail and all. It's really not a question, but a request. Can you send these slide decks out to the plans, please?
Yes, ma'am.
Thank you.
So I'm just curious, did your CMOs come back and talk to you about this policy? Are you all aware of what's coming down the pipe?
Julie has a question. Julie, you're unmuted.
Oh, I was just going to answer Gail's question. Yes, she has been talking with us about it. We knew it was coming, certainly not to this level of detail. It seems fairly straightforward. Of course, you always find out what you don't know when you implement it. But if I understand it, when there is a readmission in 14 days, the first step is to review for medical necessity, and if medically necessary, authorize it. But then if we want to review it as a readmit, a preventable readmit, we authorize it, we flag it, and then when the claim comes in, we do a retrospective review, correct?
Yes, that's beautifully put.
Okay, thank you.
Yep, thank you.
Krista Edmondson says, this is a lot to digest, and we will discuss this further internally. Valerie says, yes, they are good to go. Beth also says, yes, thank you. Gabriel says, we knew something was coming back, but not to this level of detail, so thank you. And Wilbert also says, yes, it was mentioned, but no implementation date.
Okay. So y'all, if you want to discuss this face-to-face next Friday when we meet, just let me know, and we can have further discussion about it. Oftentimes, it's when you start to operationalize something that the questions develop, and I'll be happy to have conversation around that. Emily and I are doing a webinar tomorrow with the Hospital Association to talk about it. And, you know, once again, this policy is a collaborative effort between WSHA and other community stakeholders, and then the representatives, usually from your CMO office, that attended the meetings. And it was, I'm going to say, quite interesting discussion, you know, because everyone has their position, and some people very much embrace and the need for cost containment and in regards to inpatient admission. So it was rather robust at times and very interesting. I was very impressed with some of your CMOs and how much they really understood utilization management and the value of a readmission policy and the details in a readmission policy. It was very impressive. Any other questions, guys? Going once, going twice. Well, it's been nice sharing the 2 hours with you. I look forward to next Friday seeing you all again. Further questions or need to discuss further, please let me know. There's time on the agenda. And I would hope you all have a happy Monday night.
Oh, Gabriel's got one question. We're still live. Hold on. Gabriel, could you type your question, please? The question is there any guidance about the reasonable discharge planning? In other words, ... Here it is. In other words, our SMEs have participated in conversations, but will there be an official standardization for all MCO facilities to eliminate inconsistency in expectations?
Well, I think that's a good opportunity to start in regards to our commitment to try to make sure that we are consistent across HCA and the plans. Looking for the section that talks about that. Let's talk to Emily about that. I mean, I think the bottom line is that as an RN who's done a lot of case management, you can, and a physician as well who's been ingrained in this side of the work, you look at a discharge plan, you know what the client's status was, you look at the records, you know what was required or what you surmise is required to have a successful discharge plan, and then you're looking at the orders that were written, the follow-up, the durable medical equipment, the medication, the referrals to other providers, any type of instructions about limitations in what the client or the patient should assume in regards to activities once they get home, the fact of whether or not they needed a caregiver and whether or not that caregiver was available. Those types of things are what you're looking at to make sure that you have a reasonable plan based on what you know about that client. So it's difficult to standardize because clients have specific needs that have to be met. It's going to be client specific in regards to what that plan looks like. But I think there's some general framework that we can pull together, and oftentimes a person who then is responsible for looking at that plan can often tell exactly where it fell apart, exactly what wasn't addressed. So, so I guess that's something, Gabe, that we can work on when we work towards standardization to see if we can provide any framework for that in terms of defining what's reasonable or adequate. Does that make sense?
Yeah, thank you.
Yeah. Anything else, guys?
That's it.
All right. Bye, y'all.